Good afternoon. It is the 18th of October, 12 o'clock Delhi time, and I will first speak on the PCR test and the new Abbott device, which is called the rapid antigen test, the Binax COVID test. Now, it is very important to remember that a PCR test essentially multiplies the viral gene by a process of heating and cooling, and amplifies it to a very, very large extent, in fact, to lakhs and lakhs of copies, to millions and billions of copies. And after a certain time, the test can detect that fragment or that bit or that piece of genetic material. But the PCR test does not tell us that that piece of gene of the virus is infective. In other words, you may be dropping virus genetic material, you may be carrying the virus genetic material, but you are not infective any longer. And that's the reason why Donald Trump has publicly said that he is no longer infective, because his doctors or his medical team has confirmed that fact. And how do you do that? You do that firstly by culturing the virus. This means that you take out the virus from the nostril or from the saliva and then infect cells in the laboratory. If these cells become infected, that means the culture is positive, or the virus from the patient is actually being shown to be growing in the laboratory. This is a culture positive test. Now, I am quite certain that Mr. Trump does not now shed virus which can be cultured. Now, this is, of course, a very difficult thing to do. It cannot be done by the average laboratory. But there is another PCR detection test, and this is picking up what is called the subgenomic mRNA. The subgenomic RNA implies that the virus is multiplying within the cell of the patient. Now, I have a feeling, of course, this has not been divulged by the medical team, that they probably have done this test also in Mr. Trump and found that his specimen from his nostrils or from his saliva do not carry subgenomic RNA. So remember, there are two ways of confirming the fact whether you are infective. One is by culturing that mucus which has been collected from your nose or from your throat or from your saliva, and the second is using the PCR to detect subgenomic RNA. Once you have this, then you are sure that the person is infective. Now, I keep highlighting this because of the fact that all over the world, thousands, in fact hundreds of thousands of people are being isolated or quarantined based on this test, which clearly does not indicate for certainty that the person is infected or is infective. So when Mr. Trump says that he is no longer infective, regardless of the politics in the US, I am inclined to believe him. The other thing is that we have a very interesting French paper which has actually correlated the cycles of the PCR test with the culture positivity. This means what they did was that they took specimens from people who were PCR positive at 25 cycles, at 30 cycles, at 35 cycles, and above 35 cycles. Now, what does these cycles mean? Cycles mean that you have been amplifying the virus, heating and cooling that genetic material of the virus 25 times or 30 times or 35 times. And after doing these amplifications, heating and cooling that genetic material 25 times or 30 times or 35 times, you are able to detect that fragment of genetic material. Now, this obviously means that if you take 35 cycles to pick up the genetic material, then the test is not very specific. Now, this French paper has shown that when the cycles are 25, then the chances of a culture positive is 70%. When the cycles go up to 30, then the chances of a culture positive drops to just 20%. And when the cycles are 35, then the culture positivity rate goes down to an abysmal 3%, and above 35 cycles, there is no culture positivity of the genetic material. Now, this means that for practical purposes, if your PCR test is positive below 30 cycles, or in fact below 25 cycles, then there is a chance that you are carrying a live virus. Now, I say this because a person may be shedding virus material for weeks, in fact for months, and if he turns out to be RT-PCR positive, that does not mean that the person is carrying a live virus. It does not mean that this person can infect you. The other thing is that we have these rapid antigen tests which pick up the antigens produced by the virus. These are quicker tests. They are not as sensitive as the PCR test, but they can be useful in certain situations, and a lot of companies are making them. The one which has been used by the White House is the one made by Abbott. It's called, I think, Binax COVID. Abbott had also made a Binax test for malaria, which they have always emphasized picks up genetic material produced by the parasites of malaria, but do not indicate infectivity, which means that the genetic material by itself, if picked up by the Binax test, does not mean that the person is infected. Now, the same holds true for the Binax COVID test. You may pick up the genetic material produced by the COVID virus, but this does not mean that you are carrying a live virus. Therefore, Abbott emphasizes or underscores the fact that you have to test people within 7 days of symptom onset, not after that, because after 7 or 8 days, you are shedding dead virus material or dead genetic material. And most importantly, the Binax test or the rapid antigen tests should not be used on asymptomatic people to detect COVID-19. The test is recommended only for people who have symptoms of COVID-19, which would be cough, headache, fever, myalgia, and nausea or diarrhea. So that is the reason why a lot of people in the White House were not picked up, because they were being tested by this device and they were asymptomatic. So while you're asymptomatic, you do not have that amount of viral load, because the Binax test or the rapid antigen tests require that the viral load is of an adequate quantum. Unlike the PCR test, which is far more sensitive, some people say that the PCR test is 1,000 times more sensitive than the rapid antigen test. However, the sensitivity of the rapid antigen test of the Abbott Binax COVID device is as high as 97.5%, whereas the specificity is more than 98%, almost 99%. The device is as small as a credit card. It is very simple to use. You just take the swab which is provided and encircle it in your nostril. You don't have to dig deep into the nostril, into the cribriform plate, just over here somewhere, and then put it into the device, and in 15 minutes you will know, like a pregnancy test, whether you are positive or not. But remember, this test has to be used if you are symptomatic, not before you have symptoms. And if you are symptomatic, it has to be used within a week of the onset of symptoms. So, keeping this in mind, simply getting a positive test does not mean that you are a case. So if all over the world they are reporting that cases are surging, they are surging in Spain, they are surging in France, they are surging in Germany, they are surging in the United Kingdom, that does not necessarily mean that these people are actually infected at that point of time. The other thing is that by and large, the new cases which are being picked up, or rather the positive cases which are being picked up, are amongst the young people. And we all know that the morbidity or mortality in young people is very, very low. In fact, it is almost non-existent. Even there, when Donald Trump says publicly that young people do not fall or do not get hurt by this virus, he is quite true. There is scientific evidence, and the CDC itself has brought out data. It has clearly shown that the infection fatality rate below the age of 20 is a mere 0.003%. The infection fatality rate above 20 and between 20 and 50 years is down to 0.02%. It goes up to about 0.5% above the age of 50. Between 50 and 70 years, the infection fatality rate is still hovering at 0.4 or 0.5%. So in case you are told by the mainstream media or by television channels that there is a surge in cases, do take that bit of news with a pinch of salt. Now, we move on to the Solidarity trial. This trial was a massive exercise done by the WHO, and they have presented their data on their website. Please understand that this data has not been examined. It has not been peer-reviewed, nor has this data been published in a peer-reviewed journal as yet. The data is quite raw. It is from 30 countries involving 400 hospitals and included more than 11,000 patients of COVID. But please bear in mind that this trial was not randomized. It was not even placebo-controlled, nor was it blinded. So therefore, it is not the apex of a scientific trial. However, all said and done, what the researchers have concluded is that they tested 4 drugs: hydroxychloroquine, remdesivir, lopinavir, and interferon. And they have concluded that none of these drugs reduce mortality, none of these drugs reduce the requirement of a ventilator, nor do they shorten recovery time. Now, this was more or less expected where hydroxychloroquine was concerned, because I have been again repeatedly telling you about randomized studies with HCQ. All these randomized trials in patients of severe COVID-19, in patients with mild COVID-19, in patients who have yet not been exposed, or in people who have been exposed, that is post-exposure prophylaxis or pre-exposure prophylaxis, HCQ in randomized trials has not been found to be effective. Now that is done and dusted now. We don't need to do more trials with HCQ and waste our time, despite the fact that the ICMR even now, even today, must be emphasizing that HCQ should be used by frontline workers or people who are being treated in hospitals. The second drug is lopinavir. Now lopinavir, we have randomized data. The recovery group from Oxford University has published their data a week back, and this was a randomized study in thousands of patients of COVID-19, which has shown that lopinavir did not reduce mortality. So I subscribe to that view. Recovery has also examined hydroxychloroquine in patients of COVID-19 in a randomized manner and shown that the drug was not effective. Okay. The third is interferon. Now, interferon in this solidarity trial has been used in the subcutaneous manner. Now, this cannot be the final word with interferon. Also, we do not know at what time interferon was employed in the solidarity trial, because we have randomized data published already, small studies which have shown that interferon does reduce recovery time from say 11 to 7 days, which is significant. Well, I will not harp on that, but the fourth drug which Solidarity has shown to be ineffective is remdesivir. Now this is a bit rich, because as I've mentioned, the Solidarity trial was not very randomized, it was not blinded, and above all, it has been done across the planet. It has involved 30 countries. You and I know that the quality of treatment, at least in India, differs from hospital to hospital within a city, and from hospital inside the city and outside the city. There is, in other words, a lot of difference in approaches in treating people. Medical treatment is not uniform. It's not like a television set which is made by Sony, which is more or less the same whether it is manufactured in China or Taiwan or Singapore or Malaysia or in fact in India. And the end product is the same. but medical treatment is quite different. Medical treatment given in Delhi would differ from medical treatment given in Agra, that would differ from medical treatment given in Amritsar, and that would differ from treatment given in Hoshiarpur. So what I am trying to imply, and which Gilead, the makers of Remdesivir, have also pointed out, that so much differences in the treatment protocol in various different countries will not allow us to draw a firm conclusion. And the other thing, which is also very important, is that we have no data as to at what time the Remdesivir was provided to these patients. Because remember, the randomized trials, the placebo-controlled randomized trials done so far with Remdesivir have clearly shown that recovery is shortened significantly and that there is a trend to lower mortality with Remdesivir. The last bit of data was published just about 10 days ago in the New England Journal of Medicine, which is the final report by Gilead. This has more than 1,000 patients of moderately severe COVID-19. 45% of these people, or 40% of these patients, were on supplemental oxygen, 20% were on a BiPAP, and almost 25% of the patients were on a mechanical ventilator or ECMO, which means that these patients varied from mildly symptomatic to moderately symptomatic to severely symptomatic. So we have the entire spectrum of patients of COVID-19, and the conclusions drawn by the researchers is, number one, that the recovery time was significantly shortened from 15 days to 10 days, and mortality at 1 month's time was reduced from 15% to just 11%. This was not significant, but this was moving, this was trending towards significance. The other thing which the researchers have pointed out in this trial is that on day 11, clinical recovery was much better in patients given Remdesivir as opposed to standard therapy. Remdesivir is given as an intravenous infusion. The company is now, I think, trying to make an inhaled version. The intravenous infusion is given as 200 milligrams on day 1 and then 100 milligrams for the next 5 to 9 days. So please keep in mind that Remdesivir, if given early, now this is pointed out by the Gilead researchers, by these the last randomized trial, the final report which I have just mentioned. The researchers, the authors of the paper, point out that efficacy was greater in the patients who had mild symptoms or who were on supplemental oxygen. And that makes sense because Remdesivir is an antiviral medication. It works against the polymerase enzyme. This prevents multiplication of the virus. It is an antiviral drug which has also been used in Ebola and other RNA virus diseases. So when Remdesivir is used quickly, as it was used in Donald Trump, within 2 or 3 days of onset of symptoms, then the drug is very effective. There is no point giving an antiviral after a week or 10 days of symptom onset, because by then, excuse me, if the patient has not recovered by himself, by his own immune process, then a small, a very tiny percentage of these people are degenerating into the hyperimmune response phase, wherein they require a ventilator or other means of support. And in this situation, one does not expect an antiviral to work or to operate. So now I am very surprised by this fact that the Solidarity trial, which has been covered by all Indian newspapers, is a failed trial, and none of the medicines have worked. And it almost feels as if the WHO is making a position from where it can say, once again, as it was saying 8 months or 9 months ago, that there is no treatment for this disease, so therefore we have to only and only rely on a vaccine. So we will talk about a vaccine next, because you are creating a climate wherein you are once again scaring the public that there is no drug which is effective. As I've just mentioned, that Remdesivir is certainly effective. as opposed to the other polymerase blocker, which is favipiravir. Now, favipiravir is a drug which was made by a Japanese company. In fact, this company was originally a photography company, Fuji. If you remember, Fuji used to make cameras and camera rolls. Now, Fuji has developed favipiravir, which has been used extensively in Japan, but the take-home message where favipiravir is concerned is very clear, that no randomized trial has shown either a reduction of mortality with favipiravir or has shown shortened recovery significantly reduced by favipiravir. Favipiravir is used orally. That is an advantage. It is used in a dosage of 1800 milligrams twice a day on day 1, and then 800 milligrams twice a day for the next 10 or 12 or 14 days. Neither have the Chinese shown any significant reduction in recovery time in a randomized trial. The Japanese presented an observational data of more than 2,000 patients, wherein there was a slight suggestion of shortened recovery time, but there was no reduction in mortality, and this was not a randomized trial. This is an observational study which does not even have a placebo group. There is a very small Indian trial which is yet to be published. This includes 150 patients, and there is a report on this trial in the Armed Forces Medical Journal, published I think in August, and which is a very funny paper. It is a sort of a review paper on favipiravir, and it does mention this Indian study which is randomized 150 patients, and the authors of this paper write that despite the fact that this particular paper with favipiravir has not been published, they will divulge details that recovery was shortened from 7 to 5 days, which really is not saying very much. We don't have details about the age of these patients, the sex of these patients, nor do we have details about the severity of the disease. So we have very little to talk about concerning favipiravir. But the fact is that in this country, a lot of patients are being given favipiravir despite the fact that there is no randomized data which has shown that favipiravir actually significantly reduces the recovery time or viral load in patients with COVID-19. From this, we move on to the vaccine arena. Now, it is a fact that people will be talking about vaccine ad nauseum. Mainstream media will be harping on vaccines. The entire world is waiting with bated breath for a vaccine to emerge, for an effective vaccine to emerge. But we must be sure, or if not sure, we must temper this knowledge about vaccines with the fact that if and when a COVID-19 vaccine does emerge, or when it is distributed officially in the market, the vaccine may not work in more than 50% of people. And also, we have absolutely no idea as to what are the long-term adverse effects of this vaccine. We do know that last week, Johnson & Johnson, which is in a phase 3 trial with almost 40,000 participants, has paused its trial because of some serious adverse effect. But the company has not divulged any detail about what has happened. We also know that AstraZeneca had paused its trial twice, and this trial is still paused in the United States. And the reason was that 2 women in England developed transverse myelitis, maybe because of the virus, because of a virus, or because of this vaccine. So 2 women developed transverse myelitis, which is a serious neurological condition, and because of that, AstraZeneca had to pause their vaccination phase 3 program. It is still paused in the US. It has resumed in Brazil, South Africa, England, and in India. So we must always keep in mind that the vaccine will not be a magic bullet. It will not be the silver bullet. It will not be the panacea. At best, it may work in 50 or 60 or even 40% of people. The efficacy will not be beyond that, regardless of the kind of vaccine, whether it is a Moderna vaccine, whether it is an AstraZeneca vaccine, whether it's a Johnson & Johnson, or whether it is a Pfizer vaccine. The fact is that the vaccine will just be another cog in the wheel, another part of our weaponry against this virus. Now, this is something which has to be reiterated again and again and again, because I was a bit shocked last night when I watched a video program online done by Unheard by this young man called Freddie Sayers. Now, Freddie Sayers has been doing these interviews on COVID-19 on Unheard, which is freely available on YouTube, and I would very strongly recommend you that you watch these interviews with the scientists and mathematicians on COVID-19 by this young chap called Freddie Sayers, and these videos are very good for balanced information. So I will again come back to the video I watched last evening. This had Mr. Piers Morgan, a very famous broadcaster from the United Kingdom. He is one of the top guys on television and who claims to have 6.7 million followers on his Twitter. And this means 6.7 billion means how much? That means 67 lakh followers on his Twitter handle. Now, therefore, he has a huge platform, and he does this daily morning show wherein he very abrasively and very aggressively interviews people who are willing to participate in his programs. Now, Piers Morgan obviously has, I think, on many occasions conceded the fact that he is not a scientist, he's not a doctor, he has no inkling about science. He is, I think, most probably a humanities graduate. He must have studied economics or maybe international science or social sciences or history or geography. But the fact is that he has very little knowledge on medical sciences and especially on COVID-19. But despite his complete lack of knowledge, despite having no clue about COVID-19, Piers Morgan has always been shouting from the rooftops about his opinions on lockdowns. He is a very, very strong, very, very abrasive, very loud advocate for lockdowns. In fact, he was delighted when the first lockdown was imposed on England. Maybe he had a point then, but he is now clapping or yearning for, wanting more lockdowns in England in order to clamp down on the virus, despite being told repeatedly by people that lockdowns are of little impact in controlling this disease, in controlling this pandemic. We have so much data. We in fact now have a very scientific declaration called the Great Barrington Declaration, which has been dismissed by many, but which has been endorsed by thousands of scientists. And the case they make is that at this point of time, a lot of us have been infected, and apart from not being infected, a lot of us already carry antibodies against this virus. So therefore, a reasonable amount of people, a reasonable proportion of people on the planet are already infected or are immune to COVID-19. So therefore, what we should do is not do a blanket lockdown. We should not close down everything, but rather focus only on those people who are vulnerable, on people who are old with infirmities. Now, that would be about, say, in India, less than 10% of the population. What these people have said in the declaration, the Barrington Declaration, is that because most of us, or a lot of us, have been infected, or because many of us were not infected, and because people are young, let them mingle with one another. By mingling, even if they do get infected, they will not be harmed by the virus. And the flip side would be, or rather, the advantage would be that once they're infected, they would cease to be infective and act as a barrier to the spread of the virus. Now, that makes a lot of logical sense if you use your brains, but if you just keep on yelling at the top of your voices that a lockdown is imperative, a lockdown is mandatory to check the pandemic, as the Brits are doing right now, then that would be very difficult to discuss. Now, Johnson, that's the Prime Minister of the United Kingdom, made a huge blunder, I think, with the first lockdown, based on that famous Professor Lockdown, Neil Ferguson, on his bizarre report that lakhs and lakhs of people in Britain would die. And now he's making the same mistake with these absurd graphs which were presented by his chief scientific officer and by his chief medical officer, which said that, a few days back, by October, there would be thousands of people getting infected, about 50,000 people getting infected in a single day. And by November, more than 200 people would die because of COVID-19 in England. This certainly has not happened. There are cases which are multiplying. Yes, from the earlier days, there are more cases, but they do not match the number of cases in March and April. And most importantly, these cases are not translating into admissions into hospital nor into increased mortality. The reasons are simple. Now we have some drugs at our disposal. We have steroids, we have Remdesivir, and we have the knowledge of using oxygen in these people without intubating them and attaching them to a ventilator. Now, let me clarify this further. We have data from Delhi. We have data some weeks back. In fact, I think this was in the first week of August, so this is 2 months old data, that seropositivity, or the number of people carrying antibodies to this virus, is as high as 30%. Now, 30% of 20 million is about 6 million or 6.5 million, which means that 65 lakh people have already been infected as early as the first week of August. We are still awaiting the results of the next antibody testing, which I think has been done in September in Delhi. But the fact remains the same, that if 6,000 people have died in Delhi so far because of COVID-19, the infection fatality rate of 6,000 out of 6 million people is less than 0.1%, which is very credible. This has been given by the other famous epidemiologist from Stanford, Ioannidis, who has published a paper of antibody studies across the world and come up with the figure that the fatality rate is bordering from 0.1 to 0.3%, which means that the fatality or the death rate because of COVID-19 is certainly not much greater than that of seasonal flu. So we must keep this in mind when we talk about COVID-19, that number one, in case you turn out to be positive, that does not mean you are a case. That does not mean that you are actually infected at that point of time, especially if you are asymptomatic. And the second thing is that Remdesivir, despite the fact that the Solidarity trial, which has just been presented on the WHO website, is not the final word on Remdesivir. And the third thing is that we are approaching herd immunity definitely in the city of Delhi. It may not be across the country, but because we have almost 30% people carrying antibodies, we have another 30% carrying T cells against this cell. Now, the story about T cells is not a figment of my imagination. These are papers which have been published in the most respected scientific journals called Science and Nature. 2 have been published in the last 4 weeks, and these are from Europe and from the United States of America, which have clearly shown that people who have never been infected by COVID-19, who have never been contacts of people infected by COVID-19, do carry T cells which react against the COVID-19 virus, which means that there is a very strong chance that these people were previously infected by common colds produced by the other coronaviruses. Remember, there are 4 more coronaviruses which cause common cold, and 40% of common colds are caused by coronaviruses. These are mild infections. So if you've had a common cold last year and by a coronavirus, then you have T cells in your body which can prevent an infection by the Chinese virus. These T cells can prevent infection by COVID-19 today. If they do not prevent an infection, they may ensure that if you do get infected, the disease would be of a non-serious nature or of a calmer nature, right? Now, which brings me to this subject of reinfection. Now, again, there will be mainstream media, there will be these TV channels, and there will be these hotshot chaps who take interviews online and on television who will talk about reinfection. Now, for your knowledge, there have been only 5 documented cases of reinfection. Yes, there is a report of a woman who has died, I think in Holland, because of a reinfection by COVID-19. But what they do not tell you is that this woman was aged 89. Yes, she was almost 90 years old. She was suffering from cancer and she was on chemotherapy. And this is not a published report. This is a news report. But apart from that, we have 5 reports, one from Hong Kong, one from Belgium, one from Holland, one from Ecuador, and one from Nevada, that is the United States of America. Of these 5 cases, 3 on the second instance, when they got reinfected, were asymptomatic or had mild infection, which is what I have been telling you, that in case you have T cells or if you have antibodies, then the second infection, if it occurs, would be of a milder nature. Now, there are 2 case reports which say that these people, after getting reinfected, had a disease of a more severe nature. I have gone through both these studies and I will provide links. One is from Ecuador and the other one is from Nevada. Let's talk about the Nevada case. This is a 25-year-old chap who in the month of March developed symptoms of COVID-19. He had a sore throat, cough, headache, nausea, and diarrhea. Those were his symptoms. He was PCR positive. Then he became PCR negative by April. But at the end of May, he once again became infected. He had this time fever alongside nausea, diarrhea, and cough. He was x-rayed and the x-ray was normal, but in a week's time he was admitted in hospital. This time the x-ray showed that he had patchy bilateral pneumonia. What was interesting was that the researchers found that this person, who was 25 years old, had been infected by the coronavirus, which had a slightly different gene sequence. So by definition, as per the researchers, the man had been reinfected by a slightly altered variant of the original coronavirus. But the researchers in their paper published in The Lancet do confess that they are not absolutely certain that this man was reinfected. They keep saying if he was reinfected, then the ramifications would be that even a vaccine would be not 100% proof, right, of preventing another infection. No vaccine, therefore, is 100% foolproof in preventing reinfection. The authors do, in their discussion, speculate that maybe the man was originally infected by 2 types or 2 variants of this virus, A and B. A was picked up in the first instance and B was picked up in the second instance. But they also discuss the phenomenon of antibody-dependent enhancement, AID. This is not AIDS, autoimmune deficiency syndrome. This is AID, ADE, antibody-dependent enhancement. This is a very, very important concept which I will try to simplify and explain to you. What this means is that there are times when the antibodies that are produced in our bodies can actually amplify or enhance an infection. Now, I will try to give you an example with dengue. Now, Delhi or India, in fact, is an endemic zone for dengue fever. You pronounce it as dengue. It is not dengue, it is actually dengue. And dengue is, I think, is an African term for breakbone fever. Now, dengue is caused by 4 strains of dengue virus: dengue 1, dengue 2, dengue 3, dengue 4. If you get infected by dengue 1, then you are immune in the future to dengue 1. But if you get infected by dengue 2 or dengue 3 in the short term or later on, then there are chances, albeit very small, that you could have a flared up disease the second time. You could land up with a hemorrhagic fever, which could be fatal. So, of course, this is seen in a very small proportion of cases. But this is nature. This is nature. I will repeat again that if you get infected by dengue 2, you will become immune because you will develop antibodies to dengue 2. But in the future, in an endemic zone, if you get infected by dengue 4 or dengue 3, the reality is that in a very small percentage of people, there could be antibody-dependent enhancement. That is, the antibodies which are produced to the initial infection, to the next infection, may exaggerate the clinical effects of the next infection. Now let us translate this into the vaccine program. So there is a possibility that if you get vaccinated for dengue, then the antibodies that you produce by this vaccine can make your future infection more dangerous. And this has been seen. There was a paper published, I think, in 2018, that's just 2 years ago, in the New England Journal of Medicine. The first author was a guy called Sridhar, and this was published, I think, by the company which makes the vaccine for dengue. And this has very clearly shown that in endemic zones, in children who have not suffered dengue infection, then the vaccine is okay. But if, let me repeat that, the study has shown that in people who have not been infected in the past by dengue, the dengue vaccine can aggravate a future infection. If you have been infected in the past by dengue, then the dengue vaccine can be helpful. Now, what did the researchers observe? They found that people who were uninfected to begin with, and if were given a vaccine, their chances of being hospitalized was increased by 70%, as opposed to those people who had already suffered dengue. Now, this means that in people who have not been infected by dengue, if you give them the vaccine, then there is a chance that there is what is called an antibody-dependent enhancement because of the antibodies produced by the vaccine, and this may exacerbate future infections, and that is the reason why a significant number of children who had not been infected prior to vaccination landed up in hospital, and there was also sadly some increased mortality. Now we will have to translate this into the corona vaccine, whether you like it or not, whether the companies like it or not, or whether the government likes it or not. This is all available. This is available in multiple scientific papers wherein they have shown, especially with the SARS virus, that in blood which has antibodies to SARS virus, if that is combined with a new SARS virus or which is infected with a new SARS virus, right, then there is chances of infection are far greater than when the SARS virus infects a blood which has been uninfected previously by SARS. So this is antibody-dependent enhancement. And the paper on the man from Nevada, the authors do mention that maybe this man is an example of antibody-dependent enhancement, maybe because he was infected earlier. The antibodies which were produced the second time on have aggravated his condition. But frankly, at the most, the man had some fever, he had some pneumonia. We have no details about the treatment given to him or how quickly he was released from hospital. But more importantly, the authors have confessed that in the first instance, when this chap, 25-year-old man, was admitted, or rather not admitted, but when he got infected, no antibody testing was done. Also, the second time around, no neutralizing antibodies were tested in this man. So we have absolutely no information on the antibody production in this man. So strictly speaking, so scientifically speaking, we cannot draw a conclusion on a reinfection in this man. But I will repeat what I have said, that because officially the WHO has stated that as of now 10% of the planet's population stands infected. 10% of 7.5 billion mean 750 million people are infected by the Chinese virus. That means 75 crore people are infected already in the world. If you find that 5 people out of 75 crores have a reinfection, and of these 5 people, 3 have asymptomatic reinfection, that is something one really should not scream about. So I will finish this video today. I hope you have gained a little bit more knowledge. I do gain a lot of knowledge because in preparing for these videos, which are extempore, nobody's interviewing me. I have to remember these facts and figures. I have to do a lot of studying and crystallize my thoughts. I do gain depth and I do gain information on COVID-19. And I hope you are subscribing to my channel. I hope that you are sharing these videos to as many people as possible, because yes, some effort does go into making these videos. And I have never mentioned any other channel, but I strongly recommend once again that you watch this chap Freddie Sayers, who does these interviews on Unheard, UNHERD, Unheard, and he has done some excellent videos, and you will gain a lot of information, a lot of commonsensical and sensible information of COVID-19, instead of relying on Hindi or English news channels or the mainstream media or even the alternative media in this country. Thank you very much. Have a great Sunday. Once again, bye-bye. Thank you very much.